When you hear testosterone, what immediately comes to mind? For most of us, it's probably men, right?
Yeah, I think that's the common association.
Thoughts of muscle, drive, maybe even a certain masculine energy. But what if we told you this hormone is actually crucial for women too,
Absolutely crucial.
impacting everything from your mood and memory to your energy levels and, yes, even your sex life?
That's true. And this deep dive is all about understanding low testosterone in women. We're going to unpack why it's so incredibly important,
Right.
the surprisingly large number of women affected, why it's so often overlooked, and what the latest science really says about the treatment options out there.
Okay, so our mission today is simple. Take a stack of compelling sources, find those vital nuggets of knowledge, and give you a comprehensive but still easy to digest understanding of this often misunderstood topic.
Hopefully leading to some real aha moments for listeners.
Exactly. Get ready for some perspective shifts. So let's start right there, challenging that initial thought. We mostly link testosterone to male physiology, but our sources, well, they immediately push back on that idea.
Yeah, they do. What's really fascinating here is just how critical testosterone is for women. It influences sexual functioning, mood, building lean muscle mass,
Even memory.
even memory and cognition. Yeah, it's absolutely not just a male hormone. It's like fundamental for overall female well-being.
And our sources point out this pretty significant decline over time. Think about this. Women in their 40s often have about half the testosterone they had in their 20s.
BAF, yeah, that's a big drop.
So what does that really mean for daily life? Like, what are the actual symptoms someone might experience?
That's such a crucial question because the symptoms can be really wide-ranging. Women with low levels might experience sexual dysfunction, a noticeable decrease in sexual drive or desire.
Sometimes called low sex drive or hypogonadism. Right?
Yeah, exactly. Those are the clinical terms. But it goes beyond that. You might also notice increased fatigue, maybe finding it harder to build or keep lean muscle,
Okay.
and significant impacts on mood, just that overall sense of well-being, motivation, confidence, assertiveness.
Wow, so it's quite systemic.
Very. Even memory and cognitive function can take a hit.
Here's a stat that really jumped out at me. A study in the Journal of the American Medical Association found that roughly 43% of postmenopausal women deal with some form of sexual dysfunction.
43%.
Think about that, that's nearly half. So given how common this is, what does it say that we hardly ever hear about it in women? That it often goes undiagnosed, untreated?
It's a really stark contrast, isn't it? The silence around this for women is, well, it's a huge part of the problem.
So with symptoms being so widespread, you'd think, okay, there must be readily available FDA-approved treatments. Simple, right?
You would think so.
But our sources reveal a kind of surprising truth here.
Precisely. Right now, there is no FDA-approved testosterone replacement therapy specifically designed for women. None.
Really, after all this time.
Yeah. What's remarkable, though, is that providers have actually been prescribing it off-label for over 50 years.
Off-label, meaning using it for something other than its official approved use.
Exactly.
Mm-hmm.
Using a medication for something other than its FDA-approved indication. It's common practice in many areas of medicine, but it's the only way for women right now.
So if it's not officially approved for women, how is it being administered? What are the options available if a woman and her doctor decide this is the right path?
Well, there are a few ways. Testosterone can be replaced using shallow-dose weekly injections, sublingually in a troche that's like a small lozenge that dissolves in the mouth.
Okay.
Minor surgical subcutaneous pellet insertion where a tiny pellet is placed under the skin, and also topical creams or gels.
Which one is most common?
The most common and often preferred is the topical gel or cream. These are frequently supplied by compounding pharmacies.
Ah, compounding pharmacies. So they can customize the dose.
Exactly. That's the big advantage. It allows providers to really fine-tune the dose based on the individual patient's needs, making it highly customizable. It sort of mimics how the body naturally produces hormones at low, steady daily doses.
Okay, that makes sense. So once women start this therapy, what kind of real-world improvements can they realistically expect?
They often report really significant improvements across the board. Increased sexual functioning, desire, drive, higher energy levels, too.
More energy, yeah, that's huge.
Definitely. And an improved ability to develop lean muscle mass, plus noticeable gains in mood, motivation, that overall sense of well-being and confidence.
What about the cognitive side? Memory?
Yes, memory and cognitive functioning may also see improvements. And what's really compelling is that a portion of the testosterone administered actually converts to estrogen in the body.
Oh, interesting. So it helps with estrogen-related symptoms, too.
It can, yeah. This means postmenopausal women who also have low estrogen might see relief from things like hot flashes, night sweats, moodiness, irritability, even vaginal dryness. It's like a two-for-one benefit sometimes.
And this isn't just anecdotal, right? People saying, I feel better. Our sources point to actual
Oh,
research.
absolutely. Robust research. For instance, a Cochrane review, which is kind of the gold standard for summarizing medical research, looked at over 35 trials with more than 4,500 women.
Okay.
And it showed significant improvement in sexual functioning across the board. There was also a 2014 study highlighting better memory and cognitive function with transdermal hormone therapy. So the data's there.
Okay. But like any medication, there are potential side effects. What should someone considering this therapy know about the safety side of things?
Right, safety is key. Generally, side effects are dose-dependent, meaning if the dose is too high, women might notice things like acne or increased hair growth. That's called hirsutism.
Okay, like on the face or body.
Yeah. And with extremely high doses, which really shouldn't happen with proper monitoring, you could potentially see more significant changes, like a deepening voice or enlargement of the labia or clitoris.
That sounds serious.
It is, but again, that's with inappropriately high doses. Other potential side effects could include disturbed breathing during sleep, some breast swelling or tenderness, maybe swelling in the ankles, or high red blood cell counts.
High red blood cells. Does that increase clotting risk?
It could theoretically increase clotting risk, yes. But the good news is these symptoms typically resolve if the dosage is decreased. It's about finding the right balance.
What about premenopausal women, those still menstruating? Are there extra things they need to consider?
Yes, absolutely. This brings up a really critical point.
Hmm.
For premenopausal women, reliable birth control has to be part of the conversation.
Why is that?
Because testosterone is considered Category X by the FDA. That means it can cause fetal harm if a woman becomes pregnant while she's on treatment.
Okay. So that discussion about effective contraception is non-negotiable.
Absolutely crucial. But for premenopausal women who are using reliable birth control, and for postmenopausal women, testosterone replacement therapy is generally considered very safe when prescribed at the appropriate individualized doses.
It's interesting. Our sources point out this contrast we've all probably noticed. You see ads for ED drugs for men all the time,
Constantly.
but almost nothing about treating sexual dysfunction in women. Why is there such a glaring gap?
You know, that's been a really controversial area. And frankly, it's been poorly researched and not really prioritized by the pharmaceutical industry for decades.
It seems that way.
It wasn't until June 2011, which isn't that long ago in medical terms, that an FDA advisory committee even formally stated that HSPD, hypoactive sexual desire syndrome, is a significant medical condition for women.
Wow, 2011.
Yeah, that was a really pivotal moment that hopefully might pave the way for future drug applications. But it's also important to remember how testosterone works differently than, say, ED drugs. Well, ED drugs for men primarily work by increasing blood flow to the genitals when there's arousal. Testosterone therapy for women is systemic. It works throughout the body, and it takes weeks, not hours, to have a noticeable effect on sex drive. It's not an on-demand thing.
Right, it's more about restoring a baseline.
Exactly.
So it sounds like companies have actually tried to get female testosterone products approved by the FDA before. What happened there?
They have. Several companies gave it a shot. Procter & Gamble had Intrinsa, which was a testosterone patch for women.
I think I remember hearing about that.
Maybe. It was actually rejected by the FDA back in 2004. Their main concern seemed to be about potential off-label use, even though it got government approval in Canada in 2002 and a license in Europe by 2007.
So approved elsewhere, but not in the U.S.
Right. And other companies like Boehringer Ingelheim, Warner Chilcott, and Biosante Pharmaceuticals, they had a product called Libido. They also eventually either pulled the plug on development or had their treatments rejected by the FDA. It's just been a really tough road for approval here.
Okay, let's widen the lens a bit. Thinking about general hormone therapy, or HT, for postmenopausal women, that whole area has its own controversies, right?
Oh, absolutely. Major controversies.
So how does testosterone fit into that bigger, often quite debated picture?
Well, traditional hormone therapy usually involves estrogen, sometimes with progesterone, mainly to relieve menopausal symptoms like severe hot flashes. The big turning point in that whole conversation was the Women's Health Initiative study, the WHI.
Right, the WHI study, that rings a bell.
It was this huge landmark clinical trial looking at combined oral estrogen and progestin in women aged 50 to 79. Here's the crucial part. The WHI study did not include testosterone.
Okay, no testosterone involved. And what happened?
It was actually stopped early, back in 2002, because they found increased risks of breast cancer, stroke, dangerous blood clots, and heart disease in the group taking the combined oral hormones.
Wow. That must have sent shockwaves through the medical world. Sounds like it would make doctors rethink all hormone therapy.
It absolutely did. The halting of the WHI study created widespread concern about basically all hormone therapy for women, even though the study only looked at specific oral forms of estrogen and progesterone and didn't involve any androgens like testosterone.
So a bit of throwing the baby out with the bathwater, maybe.
You could argue that. Many physicians really pulled back on prescribing HT altogether, even for women who are getting significant quality of life benefits. Now, experts are generally much more cautious, often only recommending HT if a woman has truly debilitating menopausal symptoms.
So given that history, how does this impact the conversation around androgens, specifically testosterone? Do the WHI findings about estrogen and progesterone automatically apply?
That's a really powerful distinction to make, and it's where newer information is challenging those older assumptions. If we connect this to the bigger picture, recent evidence actually suggests that androgens, either alone or maybe added to traditional HT, might actually help women with androgen deficiency who are having sexual health problems. And remember, androgens are the precursors to all estrogens in a woman's body. So androgen insufficiency can lead to symptoms like diminished well-being, low mood, fatigue, HSDD, all causing real personal distress. Premature ovarian insufficiency, POI, is another possible cause too.
So has there been specific research looking at adding testosterone to existing hormone therapy, especially given those WHI concerns?
Yes, and this is where we get another one of those aha moments. A separate Cochrane review looked specifically at this question. What happens when you add testosterone to standard HT regimens?
And what did that review find?
It included 35 trials with almost 4,800 women. The pooled results suggested that adding testosterone significantly improved sexual function scores and the number of satisfying sexual episodes for postmenopausal women already on HT.
So a clear benefit for sexual function. What about side effects in that context?
Side effects were reported as relatively few. They did note decreases in HDL, the good cholesterol, and increases in hair growth and acne incidence. But importantly, the rate at which women stopped the therapy wasn't significantly higher than placebo.
Okay, that's encouraging. Now, the big one, breast cancer. That was a major concern from WHI. What does the evidence say about testosterone's role, especially when added to other hormones?
This is probably the most intriguing part. The relationship between natural testosterone levels and breast cancer risk is still debated, frankly. And no randomized trial of testosterone therapy alone has been big enough or long enough to definitively say if it influences breast cancer risk.
So no definitive link either way from trials.
Not from large long-term trials specifically designed for that. However, there's no convincing evidence that standard estrogen-based therapy for ovarian failure increases risk. But here's the really surprising finding. A retrospective observational study from South Australia looked at over 500 postmenopausal women who were receiving testosterone in addition to standard hormone therapy.
Okay, an observational study. So looking back at patient records.
Exactly. And what they found was fascinating. The rate of breast cancer in the women taking estrogen, progestin, and testosterone was substantially lower than the rate seen in women taking just estrogen and progestin in the original WHI study.
Lower, not higher.
Lower, significantly lower. In fact, their rate was closest to the rate reported for women who had never used hormone therapy in other big studies. And their age-adjusted rate was basically the same as the general female population in South Australia.
That seems counterintuitive based on the WHI fears.
It does.
Yeah.
It strongly suggests that adding testosterone to traditional hormone therapy might not raise breast cancer risk and maybe, just maybe, could even lower it. But, and this is a big but, we definitely need more robust prospective studies to confirm this. It's a very provocative finding, though.
Definitely food for thought. Okay, so beyond low libido or adding it to HT, are there other potential uses for testosterone in women being explored? What's sort of on the research horizon?
Yeah, there are other emerging and sometimes controversial potential uses being looked at. Things like women with early ovarian failure, premenopausal women with androgen deficiency symptoms,
Okay.
also potentially for postmenopausal bone loss, maybe even glucocorticosteroid-related bone loss, HIV-related wasting, and possibly even for premenstrual syndrome, PMS.
PMS, that's surprising.
It is. Whether any of these will actually lead to approved treatments down the line, well, that remains to be seen. But the research is ongoing in these areas.
So if someone listening suspects they might have low testosterone, how can they actually get it measured accurately? Our sources mention this is a real challenge.
It is a critical point, yeah, because while hypogonadism is a well-defined diagnosis for men with low T, there isn't even a universally agreed upon name for the condition in women. Female androgen insufficiency is sometimes used, but it's not standard everywhere.
Okay, so the naming is unclear. What about the actual testing?
That's the bigger issue. Most standard testosterone blood tests, the assays, they often lack the sensitivity and reliability needed to accurately measure the much lower levels typically found in women.
So the tests used for men might not work well for women.
Often, no. They're just not precise enough at those lower ranges. The sources strongly emphasize the need for an equilibrium dialysis measure. That's considered the most adequate, most accurate method for testing women's testosterone blood levels.
Equilibrium dialysis. Okay, that's specific. So patients should maybe ask about that method.
It would be a very good question to ask their provider, yes. Without that kind of accurate test, you risk getting misleading results.
And our sources even mentioned you can buy some of these tests online now without a prescription.
That's true, yeah. In the U.S., you can buy direct-to-consumer testosterone tests for women, sometimes as part of a whole panel checking estrogen, DHEA, other hormones.
But given the accuracy issues you just mentioned.
Exactly. Given the measurement challenges, especially the need for methods like equilibrium dialysis, it's really vital to discuss any results from those online tests with a knowledgeable healthcare professional who understands these specific nuances for women. Don't just rely on the number itself.
Good advice. We talked about testosterone dropping from the 20s to the 40s. Does it keep changing after that? And how does that affect diagnosis?
Yes, it generally continues to decline during the late reproductive years. For example, that mid-cycle surge of free testosterone women usually have, that often disappears in the decade leading up to menopause.
Interesting.
And while most of the research, as we've discussed, has focused on postmenopausal women, there have been some smaller studies looking at premenopausal women with low libido.
And what do they find?
They showed improvements in well-being, mood, and sexual function with transdermal testosterone therapy. It really suggests this is an area that needs much more long-term research, looking beyond just the postmenopausal group.
Definitely. Okay, let's tackle two really big questions that always seem to come up with hormone therapy: heart health and cancer risk. Starting with the heart, what does the research say about testosterone and cardiovascular health in women?
Well, a direct harmful link between testosterone and heart disease in women has never really been definitively established. It's complex because men naturally have higher testosterone and tend to develop heart disease earlier, but that doesn't automatically mean testosterone is the cause, especially in women.
So no clear cause and effect proven.
Not a detrimental one, no. In fact, most recent observational studies in women actually show an inverse relationship, meaning lower testosterone levels are sometimes associated with higher cardiovascular disease risk.
Inverse. So lower T might be linked to worse heart health.
That's what some observational data suggests, yes. And what's really compelling here, a small placebo-controlled trial looked at giving low-dose testosterone for 6 months to women who already had systolic heart failure.
Okay, women with existing heart problems.
Right. And they found significant gains in exercise capacity, how well their lungs work during exercise, large muscle strength, and even better insulin sensitivity.
Wow, positive effects even in women with heart failure.
In that small trial, yes. And some early research also suggests that transdermal testosterone might improve vasodilation, basically.
Right.
How well blood vessels relax and open up in the brachial artery in the arm. So the picture for cardiovascular health might be more positive, or at least neutral, rather than negative. But again, more research needed.
Okay, so let's bring it right up to the present day. What's the absolute latest, most comprehensive data we have on testosterone therapy for women?
A really significant review was published in The Lancet in July 2019. It was a meta-analysis, meaning it pooled data from many studies, 36 randomized controlled trials, in this case, involving over 8,400 women.
Okay, that's a lot of data. What was the main takeaway?
The main takeaway was clear. Testosterone significantly improved multiple aspects of sexual function in postmenopausal women compared to placebo. We're talking desire, pleasure, arousal, responsiveness, even self-image, and it decreased sexual concerns and distress.
So, strong confirmation of the sexual benefits.
Very strong. It really provides a solid evidence base for its effectiveness in that specific area.
Did that big meta-analysis look at those cardiovascular markers we just discussed, like cholesterol? That's often a concern with hormone therapies.
It did, and this is a really crucial point they highlighted. The study found that a significant rise in LDL, the bad cholesterol, and reductions in total cholesterol, HDL, good cholesterol, and triglycerides were seen only when testosterone was given orally.
Only with oral testosterone, not other forms.
Correct, not when it was administered non-orally, like through a transdermal patch or cream. Those non-oral forms didn't seem to have the same negative impact on cholesterol lipids.
That seems like a really important distinction for safety.
Huge distinction. It really underscores the importance of the delivery method. They did note an overall increase in weight was recorded, potentially linked to muscle gain, but needs more study. And while things like acne and hair growth were more commonly reported with testosterone, importantly, no serious adverse events were recorded overall in the meta-analysis.
Okay, so given everything we've discussed, the benefits, the safety nuances, the delivery methods, but still no FDA-approved product specifically for women in the U.S., how are doctors actually using it in practice right now?
It really comes down to two main approaches since there are no women-specific products. Some doctors will prescribe very low, carefully calculated doses of products that were originally approved for male hypogonadism.
Like the gels or patches meant for men, but at a tiny fraction of the dose.
Exactly. Things like androgel, testum, Axiron, maybe Testopel implants for Testogel, but used off-label at much, much lower doses suitable for women. The other common approach is prescribing customized low-dose testosterone creams through those compounding pharmacies we mentioned.
Which allows for that precise, individualized dosing.
Precisely. And it's absolutely critical to remember and for doctors to calculate correctly that women require significantly less testosterone than men. The dose needs to be much, much lower. It is definitely not a one-size-fits-all situation.
Okay, that's a lot of ground we've covered. Let's try to bring all these threads together now. Thinking about everything we've discussed, what stands out to you as the most important takeaway message for our listeners?
You know, if I had to boil it down, the overarching message is just how clear it is that low testosterone in women is a real condition. It's often overlooked, frequently underdiagnosed, yet it can have these truly profound impacts on a woman's quality of life.
Yeah, affecting everything from sex drive and energy to mood and even thinking clearly.
Exactly. It's not just one thing, it's systemic.
And the good news, despite all the complexities with FDA approval and testing, is that there is growing evidence and there are practical options for treatment out there.
Absolutely.
Yeah.
That's the positive side. While it definitely requires careful consideration, hormone replacement therapy, including testosterone, can offer significant improvements for many women. It's really about being informed.
Right.
It's so important for you, the listener, if you suspect this might be an issue, to talk openly with your healthcare provider. Advocate for yourself. Ask about proper diagnosis, maybe mentioning those accurate testing methods like equilibrium dialysis.
And discuss all the treatment options, the pros and cons, to see what might be suitable for your individual situation.
Precisely. It has to be personalized.
So as you, our listener, move forward with this maybe hopefully newfound understanding, here's something to really chew on. We heard that nearly half of postmenopausal women experience sexual dysfunction.
A huge number.
Yet the conversations around it, the research focus, the available treatments for female hormones like testosterone, they still seem to be largely in the shadows compared to how openly we discuss and treat things like male health issues.
There's definitely a disparity.
So the provocative thought is, what broader implications does this ongoing disparity really have for women's health advocacy, for where research funding goes, and ultimately for the future of truly personalized medicine for everyone?
It's a big question, and one worth continuing to ask.